a very good evening to each and everyone who's taken the time out on a busy Tuesday evening to be with us here today. Yes, in typical Women's Health Committee webinar style, I already see the emojis flying. Thank you so much. I think we've got, a big shout out to all you participants there for doing this for us every single time. The emojis mean a lot, and even more so today because we have got an amazing speaker. But before I go into that, we are on episode number 4 on the Let's Talk About series of the Women's Health Committee. This time around, we have collaborated with MMA Negeri Sembilan branch. And as you know, every month we have been bringing you a high quality episode on women's health. This time is no different. Episode 4, we are talking about towards cervical cancer elimination in Malaysia, updates in practice. Before I give a brief introduction to our speaker, I would like to use this opportunity to give a shout out to my fellow colleagues who make up this amazing Women's Health Committee. It's none other than Dr. Juliet Matthew and Dr. Vani. They are the live wire, and of course, Miss Mutu, who is in the secretariat. Um, right, I see there's a hand raised. Please, housekeeping announcement. Please put all your questions in the Q&A box, and um, we will do our best to answer every single question because we have a very passionate speaker who is here to share her expertise and knowledge and take on all the questions. Without further ado, let me say a few words about the amazing lady we have with us today. Prof. Wu Yin Ling is a professor of obstetrics and gynecology at University of Malaya, or some of us would call it the UMMC, and a consultant gynecological oncologist at the UMMC. She completed her specialist and subspecialty training in gynecological oncology and postdoctoral research degree in the UK and was conferred her PhD by Cambridge University. Her research focus is on screening, prevention, and management of gynecological cancers in the Malaysian setting. Prof. Wu believes that any innovation in healthcare services must take into account the local resources with input from the stakeholders, particularly the women themselves. In 2021 and 2022, she was the recipient of the FIGO and Rachel Perline Award, respectively, for her contributions to gynecological cancers in LMIC settings. She is currently the country representative for the Asia Oceania Research Organization in genital infection and neoplasia, member of the Asia Pacific Economic Consortium, more popularly known as APEC, Cervical Cancer Working Group, member of the WHO Screening and Treatment Working Group, WHO, newly elected board member of the International Papilloma Virus Society, IPVS, and is a founding trustee to Rose Foundation. I am sure Prof. Wu would be talking to us more about the Rose Foundation once she takes center stage. Without further ado, let me present to you the shining light and beacon in the gynae oncology setting in Malaysia. Prof. Wu, the stage is yours. Thank you.
Thank you so much, Dr. Bala. Thank you very much, Dr. Siva Bala. I feel very privileged to have the opportunity to share with you a subject matter that I'm very passionate about. But sometimes the knowledge that we have may not be able to transmit and be made simple. And really my hope today is to be able to share with everyone the updates in practice in terms of cervical cancer elimination. So globally, every 2 minutes, someone will die from cervical cancer. And as general practitioner, you will tell me, look, there's so many other issues that trouble us. There's diabetes that are greater killers. There are cardiac disease, motor vehicle accidents. Why should we really bother about cervical cancer? This is it, these are the photos we take when we go on our community screening as part of ROSE. Really, mothers are extremely important. Women are extremely important in our community and in our country. And the reason why cervical cancer is such an important topic or showcase is that it is a cancer that can be eliminated in our lifetime. Billions of dollars have been put into research. We have researchers, including myself, looking for solutions and the magic bullet to eliminate cancer. But what I'm here to tell you is that today, we actually have all the tools available to eliminate a common cancer. It's a matter of how we roll the tools out. We no longer need research to say, oh, let's have better vaccines, therapy, and all that. If we use the current tools we have today, we have the ability to eliminate cervical cancer. Now, the World Health Organization has said that if we want to eliminate cervical cancer, there are really three things we need to do, and it's the life course of a woman. And who better to deal with the life course of a woman than a primary care practitioner or a gynecologist who will look after women throughout their lives? Really, really, that's why I told Dr. Siva, it's such a privilege to speak to primary care practitioner, because at the end of the day, you are central in making sure that we reach these targets in Malaysia. Now, what do we have to do? We have to talk about primary prevention, which is vaccination among our adolescents. And I'll talk to you a little bit about what are the updates in terms of vaccination. And secondly, we need to ensure that women over 30 are screened with HPV testing. And this is a very important transition from Pap smear to HPV testing, of which I hope I can share with you the data and we have enough time to take some Q&A. And the third most important thing, which we often forget, is that if you have abnormal screening, you need to have access to treatment. In Malaysia, we're very good at screening. You walk into any shopping mall, you just screen for diabetes, you screen for cholesterol, you screen for pimples on your face, your microbiome, but we never really treat. We never really think about what is the evidence-based treatment. So WHO says, look, if we have the tools to eliminate cervical cancer, how fast do we want to get there? As a country, you need to decide how fast you want to get there. So we ask the question, how fast does Malaysia want to get towards the elimination of cervical cancer? What do we have to do? Do we just vaccinate? Do we vaccinate and screen? Or do we vaccinate, screen, and make sure abnormal screens are treated? So all these clever people did some modeling, and they said, look, doctors, look, guys, look, countries, this is what you have to do. If you want to eliminate cervical cancer in your lifetime by about 2060 or so, this is what you have to achieve by 2030. So if in our lifetime, we want to eliminate cervical cancer in Malaysia, this is what we have to do. We have to ensure that 90% of our girls are fully vaccinated against HPV. The second one is the tough one. We have to ensure that 70% of our women would have at least 2 HPV tests in their lifetime at the age of 35 and 45 is the recommendation. Third is to make sure that 90% of those with abnormal screening are offered follow-up or treatment. And Malaysia committed to this back in 2020. And unfortunately, COVID hit us, which set us back a little bit, but Malaysia as a country has committed to it. And we have actually modeled, my team have worked with the WHO team, and we have modeled, if we vaccinate only, we will probably reach elimination at 2070. But if we do screening and vaccination, we can actually reach it by 2060. So Malaysia is really on track to reach cervical cancer elimination in our lifetime, and certainly I hope in my lifetime, provided we reach these targets. So very often we say, to know about what we should do today and what we should look forward to, we need to look back into the past a little bit. All of us know about George Pepper-Nicolau because he is the father of Pap smear. But many of us don't know the story behind HPV. And really, in 1982, the publication linking HPV to cervical cancer started to appear, and the literature has grown exponentially. So for those of us who are here, what happened in 1982? So when I teach medical students, they look at me and they don't know what is ET, what is a computer. But if for older people like me here, we know that in 1982, Michael Jackson had his Thriller. E.T. was a hit, and Kate Middleton was born. So that was the year of the discovery that HPV-16 is required for the development of cervical cancer. That was when it was first linked. Before that, they thought it was herpes virus. Then in 1999, I put these images here because for those who are the same age as me, they will recognize all these patterns. World Health Organization classified HPV as a necessary cause for cervical cancer. And at this stage in 1999, Matrix was a hit. I watched Matrix 1, 2, and 3, and Harry Potter became a hit among children. So you see, it's not that long ago that we discovered or we classified HPV as a necessary cause. And when you classify something as a necessary cause, this means that we will have the ability to deal with the cause and to eliminate the cause. And so we are now in a situation where we understand the natural history of the development of cervical cancer. First, women need to be infected with high-risk HPV on the cervix. Now, this process of months to years is not a one-way street. Really, most of CIN1 will regress to being normal, or even CIN2, they can still regress. So this is not a one-way street to cervical cancer. Then you say, Prof, if we get rid of HPV, is HPV the only thing that matters? Because, you know, when we study in our medical school days, we talk about cigarette smoking, we talk about the pill and everything. Well, they matter. So while HPV is a necessary cause, we need other key factors to determine whether we can clear the HPV or the infection persists. So while it is a very common infection, there are other factors that will predispose us to whether we can clear the disease or our immunity becomes compromised in such that this process takes 10 to 15 years. And so he said, well, okay, there are 200 over HPVs. What are the HPV types that really matter? And here they've done studies. So initially they looked at about 8,000 cases. Then now more recently, they looked at 15,000 cases. And what are they looking at? They're answering the question, if we have 200 over different types of HPV, what are the HPV subtypes that really, really matter in terms of prevention and causing cancer? So you can see here, HPV 16 and 18 really do account for 70% of cervical cancers globally. And when you look at the nine HPV subtypes or 7 HPV subtypes, 16, 18, 33, 45, all these types, they account for 90% of cervical cancer. And this is important when it comes to the vaccines that we offer our adolescents and women. So this is the part that we have to target. 90% of girls to be fully vaccinated. And is this research? No, this is not research anymore. Back in 2006, that was when the discovery of HPV vaccines came about. And at that stage, people said, oh, do you need boosters? If you deal with 16 and 18, maybe the other oncogenic types will take over and become the baddies. So in 2006, when the vaccines were first introduced and we started to introduce them globally, there was a lot of skepticism as to whether they will work or not. And now we have really, really robust data. In fact, I've not updated my slides. Most recently in Edinburgh, in Scotland, they've already shown that when their vaccinated cohort who are now young women, there's no cervical cancer. So those who were vaccinated and were later on screened, there is no cervical cancer among those age group. So essentially, it's worked very, very well. Now, you look at all these flags, right? You say, wow, these are rich countries. They're talking, well, maybe, with the global political situation now, it's a bit messy. How are we faring in terms of the global achievement of 90%? Really, we're not doing too well globally. You're talking about only 20% of the eligible adolescent girls that have been vaccinated with HPV vaccine out of the 90% that's required. So we say, okay, let's focus Malaysia. Let's look in to Malaysia. How are we doing in Malaysia in terms of vaccination? We know that our school program started in 2010. In fact, we have one of the best school-based programs in Southeast Asia. The cohort that has been vaccinated in school are now becoming about 26 years old. So they are coming into the age of screening. And what happened during the pandemic, COVID pandemic, is that 3 years, we did not have our young girls vaccinated because they did not go to school. But the government has done very well. Unbeknownst to many of us, they have caught up with a cohort over the last 2 years, catching up to the ages of 17. So it wasn't just Form 1. They caught up with multiple cohorts last year and this year. So we're back to above 80% in terms of coverage. So then we ask the question, before we started the vaccination, how common is HPV infection among our women? And what are the common types of HPV in our community? So my team and I in University of Malaya went around Selangor. This was one of the first studies to ask the question, how common is HPV infection among healthy women who are not in gynae clinics? These are people in the community. What is the prevalence of HPV infection in our community? And we have a prevalence of 6.5%. Now, compared to, say, Western countries, they would be about 20%, and some African countries would be about 30%. And what are the most common HPV subtypes in the community? It is 16, 52, and 58. Then we asked the question, this was pre-vaccination. What is the impact of vaccinating our girls after 10 years? Do you see a change at all? So our group went back to the same communities about 10 years later. And we said, well, what has happened to the HPV prevalence among the 18 to 24-year-olds? Because these are the ones who were vaccinated when they were in Form 1. Lo and behold, the prevalence of HPV 16 and 18 dropped by 91%. And that's consistent with international data. And if you take the quadrivalent subtypes, it dropped by 87%. Now, if you look at the far right of this graph, what you see is, what about the non-16 and 18? You see a trend of the other HPV subtypes that have been on the increase of about 18%. So these are mainly the HPV 31, 33, 45, 52, 58, which is covered by the 9-valent vaccine. Because of the effectiveness of these vaccines, there was so much write-up to say that the vaccine really has worked its way to eliminating cervical cancer. But look at the headline, in rich countries. And at that time, most Southeast Asian countries did not reach their 90% target. But I think we're getting there. Then, with the vaccines requiring 3 doses, something very interesting happened in the real world situation. Not in the real world situation, not every single adolescent got their 3 doses. So when they started to look at the big countries that have vaccinated the girls, they realized that 2 doses and 1 dose conferred the same protection as 3 doses. Then clinical trials started to take place. And as of December 2022, World Health Organization recommended that young adolescent girls and now boys requires only 1 to 2 doses to confer them protection, and it's not inferior to 3 doses. So I don't know whether most of you are aware of this. This led Malaysia and 57 other countries to change our school-based program to a single-dose HPV vaccine. So if you go to schools now, it's no longer double dose. And if you're in your clinics, whether it's boys or girls, under the age of 20, you may now offer them a single dose that will confer them protection as good as 2 or 3 doses. That's an important practice point. So from a primary care perspective, based on real-world data and based on what other countries are doing, you are now quite safe to offer a single or maximum 2 doses to boys and girls up to the age of 20. And you have the backup of 57 countries doing the same. But this does not mean that adult women will benefit from just single or 2 doses. In adult women, you still need to give them 3 doses. For those who are immune compromised, they also require 3 doses. And vaccinating boys has its benefit. It's not within today's talk to cover, but there is now very good data to support that vaccinating boys and girls will reduce the risk of tonsillar, head and neck cancers that are caused by HPV. So there are benefits that were previously not taken into account in terms of cost effectiveness. So that's my last slide about vaccination. So if you have any questions about vaccine, put it into the chat box now, or we can talk about it later, because I'm now going to spend more time talking about screening, which is the hardest topic to grasp, because we've been doing pap smears all our lives. I've been doing pap smears all my life, and now I have to transition to HPV testing. And it's not just Malaysia. This is a global transition. And whenever there's a global transition from pap smear or anything that's new in practice, what happens first? The richer countries and the higher economic countries will transition first. So we know that countries like UK, Australia, many, and the Nordic countries, the ones who offered vaccination first, they've now all transitioned to HPV testing. So we now say that the gold standard for cervical screening is no longer pap smear. The gold standard is HPV testing. And what is the recommendation? The recommendation is that we should screen women who are immunocompetent from 30 years and above with at least 2 times in their lifetime or every 5 years to 10 years. You say, Prof, why is it that some people say 10 years, some people say twice a lifetime, some people say every 5 years? This is a matter of resources. So what you want to do is you want to see the affordability of an individual or whether it's a public health program. Now, if the government is looking at screening and cost is an issue, then World Health Organization say that twice a lifetime is very good at reaching elimination targets. But if a woman says, I really want to have screening to be sure, so the recommendation is every 5 years. But current data in, say, Australia, they are now showing that maybe 7 to 8 years or even 10 years is more than enough. So watch this space. 5 years may be too frequent to have HPV testing. So where are we in Malaysia? I wish I could see a show of hands of if any one of you have seen this action plan by the Ministry of Health. It's not by it's by our Ministry of Health to say that we do want to achieve, I saw that emoji, to achieve these targets in Malaysia. And these targets are similar to World Health Organization in that we do want to reach 90% of vaccination. And we do want to offer women HPV testing. So we now have this paradigm shift. I want you to be able to tell your patients, why do you need to change from pap smear to HPV testing? Now, if I can transmit this to you in a way that you understand, then my job is done for this evening and I'm very, very happy. So let's take me. I'm going to highlight to you what I mean by sensitivity and ability to pick up a problem. So, Malaysian women, we probably have a screening test, maybe postnatal, maybe once or twice in our lifetime. And of course, maybe we have 5% of our Malaysian population who will go for pap smears every year, every 3 years, but that's a small population. So what does it mean when I say that HPV testing is 90% sensitive at picking up a problem and cytology is only 50% sensitive? So say I am a woman who walks into your clinic. In my cervix, I have a pre-malignant or a malignant condition. Say I have CIN3 on my cervix. And I come for one screening test, just one screening test, because I don't like doctors. I don't like pap smears. I just don't need to see a doctor. So I come to you only once for a screening test. If I have CIN3, you offer me a test, then HPV testing has a 90% chance of picking up that problem. If you offer me pap smear, you have a half chance of missing that problem. And people say, then why do we do pap smear? And why does pap smear work in UK? We've seen the data that pap smear works very well. Remember the slide I showed you about the natural history of how long it takes to develop cervical cancer? It takes 10 to 15 years. So if someone goes for a pap smear every year or every 3 years, even if their first test, if you miss it, you have another chance of picking up a problem. So a pap smear works very well, provided you go for it frequently. But if you go for it postnatally once or twice, it is unlikely that it'll pick up a problem. Then you say, but Prof, pap smear works very, very well. When people come in with bleeding, with abnormal periods or with vaginal discharge, we use pap smear and we detect an issue. So what many of us do, or what many primary care practitioners do, or in the Malaysian setting, women only turn up to the clinic to do a pap smear if they have a problem. So you have a biased population. You don't have a population coming in for a pap smear. So what happened is that they have something wrong with them. So they come in to have a pap smear. So therefore, they've not used it as a screening, but more so bordering to the diagnostic side. So later on, we tackle this question if you want to get further clarity. That is why we say HPV testing is definitely superior and more sensitive in detecting an abnormality. So to scale HPV testing, because in Malaysia, currently only 25% of women go for their screening test. Not 70%, definitely not 70% of Malaysian women will go for regular screening. So if you think about it, if I ask you this question, what does it take for Malaysian women, or what does it take for Malaysia to ensure that 70% of our eligible women will go for screening tests? I look at it in multiple prongs. Government can, or Ministry of Health can give you a protocol, a guideline, like what I showed you just now in a book, in a PDF. The minister or the DG will say, you have to do this. And the policy will definitely do that. But if it doesn't get to the community, it doesn't get to the healthcare professionals or NGOs, there is no linkage. There's no way of translating policy to the community. And therefore, I see this as a bilateral collaboration of what I call an all-society approach. So education and advocacy is extremely, extremely important. And while I'm not in UMMC working in my clinical work, I really do find that this is the opportune time for us to sort of influence policy and get buy-in from various bodies to ensure that we can push HPV testing forward. When I started talking about HPV back in 2017, these were the responses I got from primary care practitioners or my own colleagues. HPV test is nonsense. It's too expensive. I've seen women with cancer, but they have a negative HPV test. In my experience, pap smear is the best. So there was no way to have a conversation about how we can change practice despite the evidence. And now, the conversation is very different. The conversation says that, yeah, I believe in HPV testing, but I don't know what lab or how do I do this test. My hospital doesn't offer it. What about colposcopy? If we offer everyone HPV test, do we have enough colposcopists? So I think the conversation is shifting. The fact that I'm here today speaking to everyone shows that we are actually shifting and we are open to talking about this. But when we talk about HPV testing, we also need to address our own understanding as doctors of what HPV is. Do we have this stigma or intention to discriminate patients whom we have no issues when women have abnormal pap smears. But if women have a positive HPV test, what is a doctor's response? I'm going to show you some data that we took, a questionnaire. Some of you may have participated in it, but we sent out questionnaires to primary care practitioners and specialists. And look at these data that have come back. I mean, we really need to have a good look and think about what we as doctors, our body language and our intention to discriminate. Do we really believe that 30% of women who are screened positive have multiple sexual partners? So these are the things we need to address as primary care practitioner. And from the patient's perspective, do you know that when they have an HPV positive results, 1/6 of the women totally stop having sex. 1/3 of women are concerned that they have a sexually transmitted disease like chlamydia that would affect their fertility. So if women have these perspectives, we as healthcare professionals, can we allay and can we get rid of this misinformation? This has become such a big issue that the UICC and the Commonwealth Task Force have come up with a 12-page document to address the misconception and myths of human papilloma virus infection. So I'm going to take out some common facts for us. Did you know that in any point in our lives, 80 to 90% of anyone who's ever had sex, even if it's once, will have been exposed to HPV, 80 to 90%. And there's usually no symptoms because it's not a disease. It's not a sexually transmitted disease per se. It's a sexually acquired infection. Majority of them, 90% of them, will clear the infection. So really, the conversation around HPV infection is not one as, did you spread to me? Is it from my husband? Is it from my partner? Is it from multiple sexual partners? No. The understanding is now that most people have the infection or have been exposed. It's a matter of whether we can clear the infection or keep the infection latent. That's now the conversation that's happening among scientists and our understanding. In fact, I have not shown you the data here. When we screened healthy men in the Malaysian population, we took swabs from the oral cavity, the anogenital tract, penile swab, scrotal, and the perianal area. We found a prevalence of 60% of HPV in men who are healthy, but you can just detect HPV. So what we say is this: let's not stigmatize. Let's change our understanding to the fact that this is a common infection which we coexist with. The question here is, why do some people clear the infection and some people don't? So when we talk about HPV infection, we are really, really concerned about just 12 high-risk types. These are all that we need to be concerned about, and this is important when we talk about what test you offer patients. So what test you order really, really matters. Now, there are 200 types of HPV around. And if you're a kiasu doctor, you might say, oh, let's just screen everything. Let's not look for the 12. Let's look for high risk, low risk. Let's screen for as many as we can, because people want to know about it. But there's a huge, huge danger in this. And what I want to show you is this. This is a type of practice that we do not recommend, and the World Health Organization and a lot of professional bodies will advise against screening for low-risk HPV and also beyond the 12 high-risk types. This is because you don't know what to do. You don't know how to advise if they have low-risk HPV. And if you're a common community person or if you're a lay person, whether it's low risk or high risk, you go and Google you HPV, the word cancer, cancer, cancer comes out. It causes significant distress unnecessarily. So a very, very strong recommendation by professional bodies is just to screen for 12 high-risk types. Now, there's another component which I want to share with you. Did you know that like COVID test, 80% of commercially available HPV tests are not in line with standard recommendation? Currently in the market, there's more than 800 different HPV tests that are sold. They are even IVD approved. Some are even FDA approved, but they are not suitable for population screening. They might be useful for research, but they are not useful for population screening. And some of you may be surprised that 50% of the marketed tests, very nice boxes, very nice packaging, do not even have a single peer review publication on the test. This is exactly like during our COVID pandemic. When you walk into the pharmacies, you see a whole load of saliva tests, nasal tests, PCR tests, boxes and boxes of it. And when you go to Instagram, you see people who are COVID positive, then who have tested themselves using 7 different types of test kit. 3 of them are positive, 4 of them are negative. So we're in this situation that as private or primary care practitioners, we need to be extremely, extremely selective in what tests we use. And there are 3 questions you can ask your lab. Are you using a test that has been validated for population screening? Number 2, can these tests, are they compatible with self-sampling? I'll talk to you about self-sampling later on. So this is extremely, extremely important that you know what tests you are ordering. Then the other misconception is HPV test is very, very expensive compared to pap smear. Pap smear is $15. HPV test is $300, $200. So, but if you look at the modeling that's done, HPV screening in a lifetime is twice a lifetime. Cytology, for it to be effective, you're supposed to do it 15 times in a woman's lifetime, every 1 year to 3 years. And then taking into account its sensitivity, we now know that HPV screening is not just cost effective, it's cost saving if you use it at a correct interval at the recommended guideline, which means please don't offer HPV testing every year. Please don't just take away cytology, put in HPV test, and you do HPV test every year. No need. It's every 5 to 10 years or twice a lifetime. Then you ask, okay, HPV testing, prof, you say it's the best. Next thing you want to ask is, how do you take this test? How do you take a sample for HPV testing? There's actually many, many different methods. And what you should do is you should give women the choice of how they want it done. Some women still want to have a doctor put in a speculum, look at the cervix, see if there's anything wrong, take a pap smear, and that pap smear can be sent for HPV testing if it's liquid-based cytology, and that's called co-testing. It is not more beneficial than just purely HPV testing. Some doctors will want to put in a speculum and take a swab. Some doctors will just do a low vaginal swab without a speculum. And of course, the last option is for women to take their own swab and not have a speculum inserted at all. So I have a background. I want to show you how a swab looks like. It's actually just as simple as this is. This is a simple swab. And what you want to do is just put this in the lower vagina, you don't need to touch the cervix. This is a low vaginal swab. You turn it round and you just need to make sure you get a little bit of the mucus, and that's it. If you find as a postmenopausal woman, you may put the swab in a bit of saline first, then gently insert it in the low vagina, and then take a low vaginal swab. You do not need to take a high cervical swab. It doesn't need to touch the cervix. Many studies have shown that if you do it correctly using the right type of swab, it is as good as a doctor taking a swab from the cervix. The studies have been done. So I want to pose this to you. If your clinic is extremely busy, if you don't have enough healthcare professionals to take a swab, or you don't have speculum, really self-sampling HPV test is an evidence-based method to acquire a sample. And I feel that this is a rapid solution to ensure that 70% of our women can have at least one HPV test in their lifetime. So the data is here. You can actually Google what is the evidence that HPV self-testing is as accurate as clinician acquired. It is really, really as good as a doctor taking it if you teach them well, if they turn the swab inside correctly to get a sample of DNA. It's so accurate, so much so that the World Health Organization has now recommended HPV self-sampling as a part of the recommendation self-care method of looking after communities when there are no doctors. So in the UK, if you go to Superdrugs or if you go to Boots, you can actually buy a kit to do self-sampling and to leave it back at Boots, and they will send the results to you and you can go collect it. In Australia, I've borrowed this from Australia. This is the data or the fact that they've allowed women in Australia to do their own self-testing because they find that it does overcome some cultural barriers. Some women will never go into a doctor's office or to have a speculum examination, and therefore self-sampling works. Now, what's also beautiful about this particular swab, a Copan swab, what we call a flock swab, is that after taking the swab, it can stay in room temperature for up to 28 days before you run a PCR test. So if you're going into the interior, if you're a doctor practicing in a small practice, maybe you do one swab a day, one test a day, you can actually accumulate to say 7 or 10 over a period of a week and send it to a lab, because this is stable as a swab for up to a week to 2 weeks in room temperature. So it's really, really quite an attractive method to use in private, in your primary care setting. But there are also many, many different self-sampling kits out in the market. Not all of them have been validated. So just like there are 900 over HPV tests in the market, there's also hundreds and hundreds of different self-sampling kits that are available, not just in Malaysia, but globally. But not all of them have been tested. There's also scenarios like this, where people have run out of these swabs in the clinics. Then they say, never mind. I'll just take the usual high vaginal swab, cotton swab, to take a swab for HPV test. You can't do that because a low vaginal swab for HPV testing, you really need a flock swab, not a cotton swab. If you get a cotton swab, you won't get enough DNA for it to be a valid test. So be very careful what you use if you want to take a sample. So if you want to, this is Tedros, our WHO DG, saying this, and we know this is true. We've seen it with COVID. If you want to reach a particular target or a high standard of care, these best practices must not remain in clinics or in a book or in a guideline. What you want to do is get the information out to schools, to the streets, supermarkets, households, and often social media is used for this. And I just want to show you some ways in which Dr. Siva said about Rose Foundation. We do, as part of Rose Foundation, this is not me in a hospital, there are NGOs that reach out to communities to educate women how to take their own swabs. And so you can see here, right, even in the most remote village, these women who were in Sarawak, they were able to take their own swabs. And then we could transmit their results back to them using WhatsApp and help them to go to a hospital if they have an abnormal result. So community-based screening models are extremely important. So we know that not everyone will go to clinics, but if you are part of any NGOs, if you belong to a church, you belong to a mosque, you belong to any NGOs, you can actually do screening in these community setting nowadays. It is definitely a way to decentralize screening, thinking about how we can reach 70% of target screening in globally. Then we look at empowerment. If you have no room to screen, you can set up tents like that to screen. So self-testing in Malaysia is extremely acceptable. What type of results do you get? You only get 3 types of results. 1, it's invalid. 2 is that HPV DNA is detected, in which you need to go for follow-up. 3 is that HPV DNA is not detected, and therefore, congratulations, you can wait for your screening in another 5 to 10 years. If you have an abnormal result, you have to ensure that women are treated. Women are sent for colposcopy. So we ask the question again, how do women feel if they have an HPV positive test? And this study was done in PPUM. And what we have shown is that 88% of those women who had a positive screening test actually thought that they had cancer or something very serious. And they were extremely stressed about an HPV positive result. But after colposcopy or after follow-up, immediately their distress falls and they feel good that they've done something positive about it. What does this translate to in terms of practice? If you screen a woman as a primary care doctor and you write a referral letter, do you know how quickly they get their colposcopy done or their follow-up done in a hospital? Because it's very important that you do not wait too long between their screening test and their follow-up. And that's how you ensure that 90% actually gets their follow-up care. Because if they're extremely scared, they might just go to someone and say, just do a hysterectomy because I'm so scared. So careful thought need to be provided if you're doing screening tests. You need to deal with stigma. You need to have effective referral. So these are some of the questions you need to ask. Who refers? When you write a letter, where do women bring the letter to? Do they know which entrance to go to in terms of a hospital? If they go to a clinic, how long do they have to wait for? Whose responsibility is it to ensure that women attend? So if you have a system in your practice, what is best practice is that to ensure that if you do offer screening, is to make sure that you know how women can get their follow-up in a tertiary hospital or with a gynecologist. So this is PPUM, everything is done as a daycare facility, all very convenient because it's Klang Valley. But we really do need to understand that, the infrastructure may be different in many different places. In a lot of places, colposcopy is done as an inpatient, where they're admitted to the hospital and it's done in a main theatre. So if you're a doctor, you are referring patients to a hospital, I hope that you know that the referring hospital, you know what the process are to help your patients understand what to expect. So, how do you ensure who are the women you need to treat? So, you have done HPV testing. In Malaysia, what type of results do you think you will get? So basically, if you offer primary screening in your clinic, 6% of them will be HPV positive. Out of that 6%, so let me change this. Okay, if you screen 100 women in your primary setting, 6 women will have a positive HPV test result. So you send these 6 women to a hospital. They go to, say they come to PPUM with their positive HPV result. 8 of them will have non-16-18, whereas 2 out of 10 of those will have HPV 16 and 18. But among all the women who are HPV positive that come to colposcopy clinic, 1 in 10 will have CIN3. So which means that you can start counseling women with this type of data. If I'm in a primary care setting and I'm offering you an HPV test, I will say that if I screen 100 women, 6 of you will have an HPV positive test. So I refer these 6 to the colposcopy clinic. But when I look at these 6 women, 80% of them will actually have non-16-18. 20% of them will have HPV 16 and 18. And then we say that if you have a HPV positive test in a Malaysian setting, 1 in 10 of them will have CIN3+. Sorry, there's lots of numbers, but this is important in terms of counseling. The next slide might scare you a little bit, but it is basically to tell you that different HPV subtypes will give you a different risk of CIN2 and CIN3. Don't memorize this at all. Another way of putting this is to say that different subtypes of HPV have different oncogenicity, the different ability to cause a problem. So if a woman in Malaysia has HPV 16, I can tell them based on Malaysian data, they have a 16% chance of getting CIN3 and above. If they have HPV 31 or the other subtypes, they have less risk of having CIN3. So these are important data for colposcopists when we treat patients. But in a primary care setting, the counseling is different. The counseling is to remove stigma. The counseling is to say what are the potential positive rates. The counseling is to tell women what to expect when they go to a hospital. As a colposcopist or gynecologist, I then need to tell women they don't really need to worry about cancer, but we can reduce the risk of their cancer by dealing with the pre-cancer changes on the cervix. So where does this leave us in Malaysia? In Malaysia, more than 80% of our adolescent girls have been vaccinated. That's really, really good. Unfortunately, less than 5% of women have had HPV testing. And we don't even know, and we don't even have data. If you give a letter for those who have an abnormal screening test, what percentage actually go to a hospital or actually get it sorted out. And for that, we need to reach 90% targets. So lots of work to be done. And that's why I say it's so important for primary care to come on board to achieve these targets. So I'm going to end with the last few slides. This is Winston Churchill. He says, right, the oldest habit in the world for resisting change is to complain that unless the remedy to the disease should be universally applied, it should not be applied at all. Meaning, right, ladies and gentlemen, some of you might say, I don't know, I don't have the perfect HPV test. I don't have a colposcopist. I don't know how to counsel. But you need to start somewhere. The fact that you're here, you're starting somewhere. So if you want to offer HPV tests, you might want to ask, what lab should I send it to? How do I counsel? But please start somewhere. So in conclusion, I want to share with you the fact that elimination of cervical cancer in Malaysia is achievable, is definitely achievable in my lifetime. 2060, you know. We need to review the evidence, and we need to be able to accept that we should change from pap smear to HPV test. But if you don't know what is required, this is where our Q&A matters. But please start somewhere. And then to consider the 9-valent vaccination, because we have seen that the other subtypes are very common in Malaysia. Screening without follow-up is useless. It's a waste of money. So if you're offering screening, make sure that you have time and you know how to refer to a gynecologist or a colposcopist. And you must develop a social, culturally appropriate solution. So this is my last slide. Dr. Siva, I'm sorry I didn't include anything about Rose Foundation. For anyone who wants to know about Rose Foundation, please go to the website. Just Google Rose Foundation Malaysia. You'll see everything to do with cervical screening in the community. And I'm happy to take any questions now. Sorry, I've gone past an hour.
Thank you so much, Prof. So that brings us to the Q&A. And the first question, hi, Prof. If someone has HPV high risk positive and cytology was CIN1 or CIN3, colonoscopy done and treated, repeat biopsy came back as CIN1, how frequent do we repeat the HPV test? 6 months with colpo? That's the question.
Okay, very good question. What you're asking, the question here can be in different permutations. What you're asking me is that if someone who has been screened with a positive HPV test, you have treated it and it doesn't show any high-grade cancer, how often then should you screen again? And my response is, you can safely leave it for a year down the line if you can explain to the patient that, look, ma'am, cervical cancer takes 10 to 15 years to develop. We've looked at your cervix very carefully. The fact that you're someone who will come for follow-up, you can actually leave it for a year to do HPV testing, particularly if it's low-grade CIN. But your job is to really reassure her that in the coming year, she's not going to get cancer. So don't use the fear factor and say that, oh, I must do colposcopy every 6 months. I must do HPV every 6 months, because every 6 months it's going to be positive, for sure.
Absolutely. Thank you. And I'm sure you saw the thumbs up sign going up there that they are happy with that answer. Next question is, when do women, um, you know, the question is phrased, when should a woman do pap smear? Once sexually active or at 30 years of age? Because in medical school, This doctor was thought that once is sexually active, but she is seeing in her practice that a lady who has delivered three children, para three, has never done a pap smear before.
Correct. Excellent, excellent scenario. What you see in your textbook and reality is very, very different. That's why I'm saying that women in Malaysia, they only have pap smear para 3. And if you go to clinic kesihatan, and those who are practicing in clinic kesihatan will tell you, sometimes there's not enough beds, not enough speculum. It's just impossible because of the workload that you have to offer your postnatal women pap smears. It is just not possible. So the reality is pap smear, although it was taught in the past to be offered every 1 to 3 years, practically speaking, in reality, it doesn't happen. And so the guideline is, although our pap smear guideline was every 30 years of age, every 3 years, that guideline is gone. We should now be doing HPV testing twice a lifetime. So HPV testing can be done with a swab. And if someone is para 3 or has had sex once before, you should offer them HPV testing. I want to talk about this term, sexually active. I just asked my specialist recently, what do you understand from the term sexually active? Because, right, if you're a woman, let's say I'm in my 50 and I'm widowed or I'm divorced, you go and see the doctor. The doctor says, ma'am, are you sexually active? No, I'm not. So everybody's understanding of sexually active is different. This is what you should do. Anyone who's ever had sex, and it may even be an abuse situation, they should be offered HPV screening or cervical screening. That's the reality. So this thing about multiple sexual partners of a woman, it's not, the blame is not on a woman. If, let's say, the single partner has previously had multiple sexual partners, the woman would have been exposed to multiple sexual partners, even if she's had one partner. So don't guess who has had multiple sexual partner and whether, you are sexually active or not. The question you should ask, if you've ever had sex before, even once as a teenager, you're para 0, you're not married, you're not what, offer them cervical screening. That's the equitable thing to do. Don't put women in a situation where they feel that there's a judgment being made on that person. So to answer that question, as long as you're 30 and above, you've ever had sex, then offer them screening tests. And the ideal screening test is not a pap smear now. The ideal screening test is HPV testing. Using a swab is sufficient. You don't need a speculum if they're para not.
Thank you, Prof. And the follow-up to that is HPV testing available at Clinic Kesehatan, or
Yes.
are they still going for pap smears?
So in Klinik Kesihatan currently is a transition. All Klinik Kesihatan, as I understand it, have HPV tests, but it's limited. So certain clinics may have only about 500 tests a year. Certain clinics may have 5,000 because they have to rationalize between all the clinic kesihatan. But LPPKN also has HPV testing. Unfortunately, because of our healthcare system, hospitals do not have access to HPV testing. That's the current situation. And so very often hospitals have to outsource HPV testing. So many of my colleagues working in KKM hospitals will tell their patients to go to Klinik Kesehatan or LPPKN to have the test done, then bring the results back.
Absolutely. That's exactly what we do in Hospital Raja Permaisuri Bainon Ipoh as well. Since we don't have HPV testing in the hospital setup. The next question, Prof. If women already received the quadrivalent HPV vaccination and plan to get the nonavalent vaccine, do we still need to receive 3 doses?
Okay, so you want an iPhone upgrade 4 to an iPhone upgrade 9 lah. The answer is this: if you want to upgrade your vaccination, you have to follow the protocol based on age. So if the woman is above 20 and she has had a quadrivalent or bivalent vaccine before, and she wants to upgrade to get protection against the other subtypes, then she has to have 3 if she is an adult woman. Now, if she's 18 years old and she has had a bivalent or quadrivalent when she was in school when she was 13, and now she wants to upgrade to a nanovalent, then she only needs 1 dose as per the guidelines. So 20 years and below, single dose, adult women, 3 doses. I hope that answers the question. And if you're a primary care doctor, you also need to warn them if you have previously vaccinated against with a bivalent or quadrivalent, and you're now getting a nanovalent, your arms will be very sore and you might get a fever because your body is mounting a response against the 16 and 18 that you have previously been vaccinated against. I hope that makes sense. So for those who are upgrading their vaccines, please warn them about an extra sore arm.
Okay, thanks for that. The next one is a bit more, I would think it's you may have to give a disclaimer that you don't have any shares with any of the vaccine companies, because the question goes like this: between the various HPV vaccines, Cervarix, Gardasil 4, and Gardasil 9, which would you recommend for vaccination in a young teenage girl or boy, as in terms of efficacy?
Okay. I have been advocating and I have been pushing for the highest valent vaccine purely because of our data. It's not my preference, but it's whether we can afford it or not. It's all a matter of affordability. If I am advising an individual, I would say that if you can afford to pay 500 ringgit for a single dose of 9-valent, by all means, go for it, because it's equivalent to maybe 3 outings when they go out at night to makan. But if I'm advising a government, then they have to look at the cost, because government will say, I have to pay for dengue vaccine, I have to pay for pneumococcal vaccine, I have to pay for so many vaccines. How do you expect me to pay for Gardasil 9 as well, the 9-valent vaccine? But I would say for maximal protection, I would definitely go for the 9-valent. And if I have money, I would vaccinate the boys and the girls.
Right. Thanks, Prof. Any role of HPV testing in women with cervical cancer post-treatment for surveillance?
Okay, so it depends what they have been treated with. So if you've treated someone with a early stage with radical hysterectomy, then you can use HPV testing to identify the risk of local recurrence. Because if they're HPV negative, you're quite sure that they won't have local recurrence. HPV testing can never give you an answer for systemic or distant metastases. So particularly those who've had radiotherapy before, you know that if they've had radiotherapy, the most likely place of recurrence will be outside the pelvis, para-aortic, cervix area, the cervical lymph nodes. So as a test of cure for someone who's had radiotherapy, you can never guarantee that they won't get any issues elsewhere besides the cervix. But if you have a negative HPV test, what you can say is it's unlikely that you'll get local recurrence, vault recurrence. I hope that answers the question as well.
It does. And next question is there an authorized list by KKM regarding test kits that are meeting the standard requirements?
Okay. KKM won't name the brand, but KKM will give you the criteria required for the test kits and the HPV test. So they won't name it, but if you follow those criteria given, you will automatically know what they are.
Okay. Is it true that you can't do an HPV test during pregnancy, but you can do a pap smear test during pregnancy? And why is that?
First of all, it's untrue. Okay, I have shown you, and I hope that we will be able to produce data on a publication to show you. Look, I have shown you that a swab like this, you can do a low vaginal swab and you can do HPV testing with this. In pregnancy, many studies have been shown that when you take a cervical brush or a pap smear in a pregnant cervix, it's not very accurate. You might bleed as well. But if you take a low vaginal swab, it is very accurate, and we've demonstrated that in PPUM, and the paper is being published. So what we've done is we've screened 1,600 women with a low vaginal swab. In fact, we didn't screen, the women did the screening themselves. And the accuracy and acceptability is similar to the general population. So we talk about taking swabs for GBS, Group B strep. We talk about digital examination. People worry about HPV testing in a woman during pregnancy, but what you are really doing is just taking a simple low vaginal swab. Shouldn't cause any harm, and the PCR should be sufficient. So in places like Australia, they do offer women HPV testing if they want to in pregnancy.
Okay. Prof, we've got tons of questions here. Are you okay for time?
I'm okay for time.
Okay, next one goes like this. A sexually active teenager, 18 years of age, comes over to the primary care setting for pap smear / HPV. And the question is, the age is not a contraindication to do the pap smear or HPV, is it?
Okay, fantastic question. HPV testing is a cervical cancer screening test. You are not testing for a sexually transmitted disease. So when a teenager or for cases of rape that has come through A&E, where you do a whole panel of sexually transmitted disease screening, HPV is not one of them. So when a young person comes to you in a panic, they've had a good party, or even in a not so nice situation where they've had unprotected, non-consensual sex, HPV testing is not part of the panel. HPV testing is a cervical screening test to be offered from the age of 30 above. Why do we not do it from 18 to 29? Because it is likely to be positive. I shared with you, HPV infection is very common, and it is most common when you're first sexually exposed, because it is a sexually acquired infection. But it is not a disease. There's no antibiotics. You don't need to contact trace. It doesn't cause vaginal discharge. It doesn't cause infertility. What happens is, if you don't clear HPV, high-risk HPV infection in 10 to 15 years, then you're at risk of developing cervical cancer. But please do not offer HPV testing as a sexually transmitted disease panel. I hope that answers the question.
It's perfect. And in your experience, what are the most common mistakes or misconceptions doctors and patients face during the conversation of HPV testing or cervical cancer screening? I believe you covered that
It's
in your
worth
talk earlier.
talking about it, and I think we need to address this better. I think we turn it into a blame game. When we do HPV testing, and some of my colleagues and some doctors even say that, oh, then we should screen your partner as well. because you are HPV positive, we should screen your partner. There's no necessity to do that. The most common misconception is to treat it like a sexually transmitted disease and to stigmatize it. My counseling for patients is that it's similar to chicken pox and shingles or herpes. When you're stressed, you get cold sores, but it's a virus that's latent within you. HPV infection is similar. It is a latent infection in most people, and during times of stress, it might appear again. But if it's well controlled, then you won't have abnormalities surfacing on the pap smear or cytology.
Thank you. And the next one is they would like to confirm, do all HPV positive women need colposcopy referral, or only the highly oncogenic variants such as the HPV 16 and 18?
Okay, this one is a whole lecture in itself for an hour. Do you screen and treat, or you screen, triage, and treat? Now, what I would say to the person who asked the question is this: if you screen and a woman is HPV positive, and this woman is unlikely to come back for pap smear, come back to clinics often again, you want to make sure that this person gets treated by or get seen and get colposcopy and get their cervix treated in one visit. Because many of our B40 women they don't come to clinics. And so when you have a screening test, you say, oh, come back again for pap smear. And then after that, come back again for colposcopy. 80% of them don't even come back for pap smear. So guidelines will say that if you have a population that is unlikely to come back for frequent follow-up, that they are from a community where you only see them once, then you do a screen and treat, which means that if they're HPV positive, all of them, you just bring them for colposcopy, or in certain places, VIA, look at their cervix and then reassure them there's no cancer. Which brings me to another situation where you have HPV 16 on the HPV test. But then when you do colposcopy, there's nothing at all. Pap smear is normal. Everything is fine. What do I do with that woman? But you only get one time to see her. And in many places, what they do is they offer a simple treatment such as thermal ablation, or they might even do a simple ablative method with a ball diathermy, or they treat it because they're afraid of a future risk of developing a problem. Of course, I won't do a cone biopsy or hysterectomy. What it means is that that woman has HPV 16 at that point in time. But I can't guarantee in future whether or not there will be an issue, because you're getting a snapshot in time. But our data in Malaysia shows that if you're HPV 16 positive, you have a 1 in 5 chance of having CIN3.
Thank you. And the next one is, does it mean that pap smear done at 6 weeks postpartum can now be replaced with HPV testing alone?
If the lochia is not very heavy, you don't have a lot of blood, yes, it is.
Okay. And is it still true that booster is no longer needed, a booster dosage of the vaccine?
As far as we know, data up to 16 years shows that we don't need a booster.
Okay. And yeah, a pap smear with HPV test is with a negative HPV and reactive inflammation on cytology. A suggestion to repeat smear was given. How should I approach the repeat screening? Is it also 5 years?
Yes, 5 or even 10 years. If your HPV test was done on a validated HPV platform, then you don't need to repeat that. But you might want to repeat their other, they might have other infection that has caused a reactive pap smear. They might have candida, they might have bacterial vaginosis, chlamydia, or whatever. So you might want to do a swab for other things, but not for cervical cancer risk.
Okay. Right. next one is interesting. If money is not a concern, when should the patient have her last HPV DNA screening done if she's doing it regularly every 5 years, right? Um, so when would you say, okay, you know what, you're done. After this, you don't need to come back for a testing.
Okay, hard to answer, but 65 is the guideline. 65.
All right.
The reason why I say it's hard to answer this is that the first country that is going through their second round of HPV testing is actually Australia. So their
Mhm.
first round of community of population screening was in 2017. 2017, they found quite a lot of abnormality. Now their second round, their screening, they say, where are all the CIN 2s, 3s? Where are all the problems? No more
Mm.
problem already. The first round of screening got rid of all the problem. And now 5 years down the line, I have no issues. And now they're thinking of revising to see whether it should be 8 years or even longer to say that you don't need to screen every 5 years. So
Excellent.
it's really quite interesting. It's an evolving situation.
Sure. And further to that question, the doctor goes on to ask, and for those who never had it done, the HPV screening, and only came to the clinic at age 69 years, could we then do one
Yes.
since she's 16?
Yes, of course. Anyone who's never been screened if they're healthy, even at 75 or 80, I would screen them if they are well, because they've never been screened before. So guidelines of stopping at 60, 65 are those who have been regularly screened. Otherwise, you need to offer screening for someone who's never been screened before.
Dr. Sharifa says, hello, Prof. Thank you so much for a very informative session. And her question goes like this. For a woman who is not sexually active, most of them will refuse speculum or even a low vaginal swab. So can we then screen this group of women using a urine sample for HPV DNA?
So urine sample has been shown to can be used as a method of screening, but the sensitivity is less than that of a vaginal swab. So the sensitivity in picking up an issue with a swab is about 92 to 95%. With the urine test is above 80%. So it's about 85%. So urine test can be used, not as sensitive, but very few women would refuse a low vaginal swab lah.
Right. And again, the next doctor says, thank you so much, Prof, for a very informative talk. For women above 60, is it recommended to give the HPV vaccination?
No, the effectiveness of the vaccine above 45 years is of no, if is really, really limited. And the best thing to do is actually to screen them. At 69, you screen them, they're negative, it's sayonara.
Right. And a rather personal, heartfelt sharing here by Dr. Shasha, who says, hi, Prof, not a question, but I had a class with you back in 2015, a good 10 years ago, during my undergrad studies, and still I have a photo of it on Instagram. We truly enjoyed the class. So there
When
you have
was
it.
that? I can't remember that.
Okay, 10 years already. So you've got a fan following of your own, I'm sure. Do we have guidelines in HPV test follow-up in patients who had CIN?
Yes, we do. So if you've had CIN, in fact, if a patient has been treated for CIN, there is value in also advising them to be vaccinated, because vaccination of a woman who has had CIN will reduce the recurrence rate. That's the first thing. The second thing is that you will have a repeat HPV testing usually in about a year after that, because that's a test of cure. So if after you've treated the CIN, you repeat HPV testing a year down the line and it's negative, then what you can do is you can put them back into the pool of normal screening, which is every 5 years or 10 years.
Perfect. Cotton swab is not to be used for sampling. Can you repeat your reason? I didn't hear it well earlier.
Okay. If you go to the Program Rose YouTube channel, you will see me demonstrate. So this is what this is a flock swab. This is a flock swab in the sense that it's made to capture DNA. So if you look at it under a microscope, it looks a bit like a Christmas tree with lots and lots of fine nylon fibers. And when you put it into the vagina, it captures DNA, captures mucus and all that. And that one will capture enough HPV DNA to run your HPV testing, DNA testing, PCR. So you need a flock swab for PCR test. A cotton swab is used for culture and sensitivity. It is not good enough to capture DNA for PCR. In fact, there may be a lot of contaminants. So the black tip one for high vaginal swab is used for culture and sensitivity. Flock swab is used to capture DNA for PCR. So it's not interchangeable.
Thank you. Would HPV screening be recommended or required for individual post total total hysterectomy? Histopathology report says no dysplasia or metaplasia over cervix.
No need.
Okay. What about non-HPV cervical cancer? I think that's a whole lecture on its own, but
I
that's a
think,
question.
yeah, people forget that there are other cells on the cervix as well. So for us, I've seen lymphoma arising from the cervix. That's not HPV related. You can have neuroendocrine tumor, small cell tumor. All these are all classified as cervical cancer. Now, when we talk about HPV-related cancers, you're really talking about epithelial cancers, the epithelial squamous and adeno cancers. For the rare ones, they will be HPV negative. If you talk about lymphoma of the cervix, if you talk about small cell cancer of the cervix, these are cervical very, very rare cancers. That's why they will say that, you know, it's 99% of cervical cancer is HPV related. It's not 100% because there are other cell types that are rare in the cervix.
And the next question alludes to training because the doctor is asking what is the general consensus or current scenario in Malaysia with regard to colposcopy and colposcopist. In the UK, there is the BSCCP with regards to training standards and performance. What is your opinion, Prof?
Yeah, we don't have, I don't think we are likely to have a stringent and organized training like the BSCCP. I can tell you my colleagues in Singapore, my colleagues in Hong Kong tried to emulate SCCP or HKSCCP. It was never possible. But what I'd like to encourage us in Malaysia is that there are going to be colposcopy courses that will be run. In the next one will be, in fact, at OGSM, we will be having a pre-congress workshop where we will talk about colposcopists being ready to manage simple cases. In fact, in many, many countries, primary care doctors are now starting to offer colposcopy because they have this simple mobile colposcopy, and there are now what they call thermal ablation. You don't need to have a loop or LEDs, and GPs who are trained can actually do simple procedures to rule out cancers, to offer basic treatment in their clinic. I think if we were to start to offer 90% women follow-up, we should be looking at training of our workforce, healthcare workforce, and not just gynae oncologists to perform colposcopy.
Thank you. And the next question is, if patient was tested positive for HPV DNA low risk subtype, is HPV vaccine then beneficial to these patients?
No, which subtype? I mean, 6 and
They just
11?
put it as,
No,
yeah,
not
low risk.
really. No. Please don't screen your women for low risk HPV, please. Even if your test comes out, please don't reveal it to them because it's inconsequential except for causing anxiety.
Absolutely. If HPV test shows no intraepithelial lesion or malignancy, NILM, with reactive changes with fungal infection multiple times, do we treat again and again? Patient is low risk, postpartum, and no high risk behavior as such.
Okay, a few things here. So HPV tests won't come out as NLIM, that's a pap smear. So only in pap smears you will see cytology as showing NLIM and with candida, fungal infection or whatever that is. And if it's recurrent, then you need to give 6 months worth of a prolonged treatment for antifungal infection. Low risk HPV, I will not test for it and I will not treat it. I won't even bring it up to the patient. Now, you have situations where you have your HPV test is positive, negative, and you have a ascus pap smear. For those cases, you can actually reassure them that they are not at risk of developing cervical cancer if you have used a validated test. So for me, I'm practicing in PPUM, we use a validated HPV test. If the test is negative, I know my lab is very stringent. Prof. Jamal does a great job. They have audits, they have quality control. I dare to tell the patient, no worries. But if I'm ordering a test from a lab that I'm not sure about the quality, then I start to worry. Can I reassure them that they don't have a risk of cancer?
Right. And what is the likely cause of persistent pelvic pain for women who had undergone LLETZ? There is no vaginal discharge and no dyspareunia.
It's probably unlikely to be due to the LLT-ETZ because it's a very localized treatment.
Sure. And final two questions, Prof. Thank you so much again for your time and staying on this late with us. But just to inform you, we have got more than 200, close to 230 participants still online, as always, interested and dedicated to the cause of women's health. So, final two questions. Are women with para 3 recommended to take HPV vaccine? It's kind of late, but how much does it protect?
How old is she?
They did not give the age.
Okay.
So I thought that was
So,
the part where,
so
yeah,
basically you're asking adult women. So if it's an adult woman, the efficacy or the effectiveness of the vaccine is not as good as that in an adolescent, but there's still benefit. So if the woman can afford to pay, if she's under 45, sure, why not? Go ahead.
okay. And after this, can I discharge patients for HPV after 6 weeks postpartum at Clinic Kesihatan if she is more than 30 years old?
HPV test negative? What's the question? Sorry.
Rather vague because it goes like this. After this, can I discharge patient for HPV, I suppose when it comes back negative, after 6 weeks postpartum at Clinic Kesihatan if she's more than 30 years old?
Okay, if
Not very
she
clear.
is, okay, I'm assuming if you're asking me that if she's HPV test negative and she's after 30 years old, can you discharge from Clinic Kesihatan? Ideally, you can discharge as a postnatal patient, but if you have the ability to bring them back at the age of 45 or you tell them 40 lebih, tolong datang balik untuk test or go to LPPKN.
Right. Um, and Dr. Bhupinder would just like to record, Bhupinder Kaur would just like to record her thanks. Thank you, Prof. There. And then there's another request. Dearest panel, please share a recording of this session. Would that be okay with you, Prof?
Yes, of course. The recording, please share. Also, I want to say that on the MMA website, there's actually 3 lectures, short lectures, 20 minutes, 20 minutes, 20 minutes, each with CPD points of 1. on this topic in greater detail. For those of you who are interested to run community programs and you are part of a community, not necessarily in your practice, please go to the website of Rose Foundation, where you can see how we can run community programs to screen the underserved population. Lots of information there.
Brilliant. Thank you for channeling the crowd to the MMA website as well. And I think one for the road, final question pops up, Prof. If both wife and husband found to have HPV high risk type at age of 48, will you recommend Gardasil 9 vaccine to them if husband still sexually active with other casual person? Would you
Okay.
still recommend Gardasil 9?
There's no data on the efficacy of vaccines being effective after the age of 49. Look, males are very commonly HPV positive. And like I said, I hope that everyone will stop using the term multiple sexual partners. This person is sexually active with early sexual onset, because really what we're talking about is screening for a cancer. We should screen them as per protocol. We can vaccinate them as and when they need it, if they have the resources to. So any man or woman under the age of 45, if you can afford it, please go for Gardasil 9 regardless. And if you're a woman that's above the age of 30, if you have resources, screen every 5 years. If you don't have resources, twice a lifetime.
And the same doctor goes on to ask, if a lady found to have high risk HPV at age of 40, one with normal and one with abnormal pap smear, after how long to repeat the HPV DNA test for both of them?
HPV test that's positive, go for follow-up, and it depends on what abnormality is discovered. For the ones who is HPV negative, it will be after 5 to 10 years.
And one doctor here would like to know that I am 1991, that's how it's phrased, so I take it she's born in 1991. Am
How
I
old is that?
eligible for free vaccination? That's the question.
How old is that?
91, 01, 11, 21. So that's 34 years of age.
No, you're
Is
not
she still
eligible. No,
not
you're not
eligible for free?
eligible, and you should go for 3 doses of whichever you choose to have.
Right. And Dr. Shafia says, thank you, Prof, and thank you, MMA. And as Prof clearly pointed out earlier, you see, you've all been an amazing audience with more than 200 of y'all still here for one CPD point. And she says, go to the MMA website and you can still get that one CPD point after 20 minutes. So, but nothing like listening to you, Prof. So, with that, I thank you again so much for your time and that very comprehensive. You can see all the emojis flying, right,
Yeah, I can
Prof?
see. I want to take a
Yeah.
screenshot of this
Yeah,
actually.
please do, because that is how Women's Health Committee organization and all our members, right? This is just amazing. Like, I do not know how the screenshot works. So I'll just use my phone.
I can't
I'll,
screenshot it, but it's so,
I'll send you the photos.
gosh.
Yeah, yeah. This is what we get for each of our talks: overwhelming positivity and response. And there you have it at what time is it now? Close to 10 p.m. again, 9:45. All those wonderful audience there. And Prof, thank you so much to all of you out there who are listening in to us. Thank you so much. We'll be seeing you next month, very soon, early next month, the first half. This time on an obstetric talk. Poster will be out soon, and I will see you in the next one. Thank you. Good night. Stay safe. Thank you,
Good
Prof.
night. Bye.
Bye. Good night.